Hello, sir.
Onkar, if you're ready, we can.
Introduction చేయాలి కదా శ్రీకాంత్ చేసి తొందరగా.
ఒక 2 minutes, sir. 2 minutes. I'll start 2 minutes.
Sir, Onkar కి ఎందుకు సార్ ఇంట్రడక్షన్ మెగాస్టార్. Okay, ready? Okay, 2 minutes. And meanwhile, so today, speaker, as you all know, Dr. Jagdish Onkar, senior anesthesiologist, currently working in ABC hospitals. So the topic is thoracic segmental spinal anesthesia. In the recent years, it has been gaining popularity, this technique, especially in sick patients and all, so that we can avoid general for surgeries like cholecystectomy and upper thoracic surgeries and all. So there are quite a few studies regarding thoracic segmental spinal, and also there are a lot of Facebook anesthetist group. There are a lot of threads. I will share few of them, search few of them, and share it here. So in those discussions and all, this being practiced in Western world since long, and now actually in our part also, so many cities segmental spinal is being practiced. So we'll gain some knowledge through this class and see if we can practically apply it in our regular anesthesia practice. Thank you. Onkar, when you're ready, you can start.
శ్రీకాంత్. Hello.
Hello, sir. Sir.
Make sure that today evening everybody comes to the class. All of you please promote it and make everybody comes, sir.
Sure, sir. Sure.
Nice, sir. One, sir. Sir, Srikanth, sir.
Yeah, start it. Onkar.
Good morning, all. Today I'm going to talk about thoracic segmental spinal anesthesia, which is practice only, but nowadays very less number of people are practicing it. So coming to the history introduction. So all anesthesiologists, spinal anesthesia is a bread and butter, which was initially started by August Bayer in 1889, and the procedure in which we puncture the subarachnoid space and we see that CSF is there, and after that we started setting our thumb. This is the age-old practice which we are doing. But later on, in 1909, Thomas Jonas Hope, he came out with something similar. Technique is the same, but opinions. There is what he suggested is try to give spinal as close to the what you call surgical area. Like if it is a thoracic area surgery, we can give spinal in thoracic itself. No need to give spinal in the lumbar area and see that level essential in thoracic segment. So he says few surgeries like giving head and neck for head and neck surgeries, thorax surgeries, measuring the subarachnoid size between thoracic first and second vertebrae. And later on, this procedure was elaborately studied. Different techniques were introduced, and different surgical interventions were performed in regional only. Previously, which used to be done in general or else lumbar spinal. And later on, we started practicing by puncturing mid-thoracic and lower thoracic level for almost every thoracic surgery and even abdominal surgery also. And after that, what do you call, in 2006, the new era of studies on segmental spinal anesthesia started. But before that, in 1909, Thomas Jonesco suggested that giving spinal near to the surgical site, which was later on altered in 1932, where there is technique what do you call suggested in which lateral position patient is kept in lateral position and trundling position, and they used to perform subarachnoid puncture, and they used to remove around 1 to 2 ml CSF fluid, after which drug was administered. And later on, they used to push 1 ml of air column. So their concept was, if you are putting an air column in that space, the air column will ascend capillary in direction, and it will be pushing the drug above it towards the capillary region. But later on in 1937, this procedure was what you call a bit of modifications were done. The pushing air column stopped because the patients used to have what you call severe headache, and some of them landed in stroke also. So this was air column was replaced with the saline injection. In another technique, 1934, two needle technique was introduced, where they used to do two punctures. At around cervical level, they used to put one needle, and in the lumbar region, they used to put one needle. They used to deposit 1 ml at the lower level and 1 ml at the upper level, so that the thoracic segment should be completely blocked. And later on in 1946, there's something new, that is continuous segmental spinal anesthesia, where they put a do subarachnoid puncture, put a catheter there, and slowly they started giving drugs. These were done in 1946 itself. And coming to 2006, they started using this segmental spinal puncture for laparoscopic cholecystectomy. They selected a patient who is having severe lung disease and was very much unfit. No, we cannot say unfit. Difficult for general anesthesia, and with respect to his lung conditions. So they worked on segmental spinal, and they gave spinal in T10 level for lap cholecystectomy. This was done by Van Zundert. Later on, from once this study was published, people started exploring a lot about segmental spinal, and they started utilizing surgeries for utilizing segmental spinal for many surgeries like thoracic surgeries, laparoscopic cholecystectomy, breast surgeries, etc. So we normally call it as segmental spinal, is often widely used as, synonymously with thoracic spinal anesthesia. But what the real meaning of segmental spinal is, it is we are blocking required dermatums, which are essential for our surgical procedure, and that too with a low amount of drug dosage. So the exact definition of segmental spinal is blocking the dermatose at the level which we are planning surgery and with minimal amount of dose. So this often necessitates dural puncture at high lumbar or thoracic level, apart from the conventional one. So lower the dose of local anesthesia drugs used, more likely it to produce a true segmental spine. So the amount of drug we are using is less. I will be talking about that in coming slides. What are the three main issues which we will be encountering when we are not following our conventional level giving spinal anesthesia? First thing is risk of neuronal injury. Second thing is respiratory embarrassment due to excessive thoracic nerve blockage. Capillary spread of local anesthetic drug causing high or total block. As we know, according to anatomy, our spinal cord ends at L1 in adults and L3 at pediatric age group. So below giving L1 was very much comfortable. Initially, our studies showed that it is very much comfortable giving L1. We will avoid and all. But this starts telling us about what you call. You can even go for thoracic segmental spinal also, and we can even avoid spinal cord damage. And they were given some anatomical measurements, and anatomical studies were done to prove that this was not going to damage the spinal cord if we are giving spinal at even thoracic level also. Hello. Sorry, sir. So these are the main issues. So many studies were used using myelography, which showed that thoracic cord lies anteriorly in the theca, while lumbar cord is situated most dorsally. So the space between the dura and spinal cord, which is normally the measurement of the space in lumbar area is around 3.4 mm, whereas in cervical it is 2.3 mm. When you're coming to thoracic segments like T2, it will be around 4 to 5 mm, whereas T9, T6 to T8, it will be around 6 mm. So repeated MRI studies showed that we are having ample space that is between dura and spinal cord in thoracic segments, especially T6 to T10. So if we are even planning segmental spinal also, we are very much what you call safe, and we cannot easily what you call damage the spinal cord. Okay, so this is what I'm telling. Here, some measurements. The T2 it's 5.2 mm. It's T5 it's 7.75 mm. Whereas in T10 it's 5.88 mm. So all these measurements which show the distance between dura to spinal cord, which are more than lumbar space. Where in lumbar space, as I told, it is 3.5 to 4.5 mm only. So this study was accepted by most of the councils, suggesting that we can go ahead with segmental spinal also. And some issues which were discussed on giving thoracic spinal. Extensive thoracic nerve blockade leads to paralysis of anterior abdominal wall muscles, which may lead to some impedance in forceful expiration and cough. So thoracic nerves from T1 to T12, these spinal nerves will be coming from the thoracic vertebrae. And once we are giving spinal and if we are giving high dose, these nerve roots are blocked densely, because of which the patient will be having respiratory difficulties. So to avoid this, they started using low dose of drugs so that to preserve the coughing ability of the patient and minimize the what you call minimize the nerve root block so that expiratory muscles are not completely knocked down. So cough reflex is there and patient is able to expirate well. So patient can comfortably tolerate the regional anesthesia. Coming to heart rate can be decreased if there is a high neuraxial block because of blockade of cardioaxillary fibers, which is arising from T1 to T4. But as the right atrial filling is maintained, why it is maintained? Because lumbosacral plexus are spared and less vasodilatation in lower limbs. So there is pumping of what you call venous return is not at all compromised. So atrial filling is consistently maintained. Okay. So because of which it sustains the outflow from intrinsic chronotropic stretch receptors located in the right atrium and great vessels. So there are less number of chances of having hypotension also. Okay, so till date, segmental spinals are being only used for high-risk morbid patients for selective surgeries only. And as the success of this procedure is increasing in complicated cases, so people are starting to perform what you call make it a routine practice to give segmental spinal for most of the surgeries, especially abdominal surgeries. So segmental spinal wide angle perspective, yes, practically all abdominal surgeries, upper abdominal, lower abdominal, minor or major daycare surgeries, laparoscopic surgeries, all can be performed with segmental spinal alone. If needed, we can combine spinal and epidural also. If that's not all, then the option of CSSA, that is continuous segmental spinal anesthesia, is also available. But most of the studies, they did either with single segmental spinal alone or with the combination of a segmental spinal and thoracic epidural. Very less number of studies are published with continuous segmental spinal anesthesia. Okay. So depending upon the type of surgery, patient's hemodynamic status, and associated comorbidities and comorbid conditions, the dose of local anesthetic agent and site of injection along with the neuraxis can be varied. For all the abdominal surgeries with adequate dose, thoracic spinal above T10 is hardly required. So space between T10 and L1 is usually sufficient for all abdominal surgeries. So this is what I already told. If you are planning to go for abdominal surgery and segmental spinal, ideal space is from T10 to L1. Above L1 and up to T10 you can go. If furthermore like breast surgeries and all, prefer going between T5 to T10. So on an average dose of 7.5 to 10 mg, that is 1.5 to 2 ml of bupivacaine or levobupivacaine with some additives like fentanyl, clonidine, it will be helpful. And a duration of around 90 to 120 minutes, effect was seen in most of the studies. But there are studies which suggest that you can even by additive extend the segmental spinal effect till 3 hours. This dose is exactly half the amount required when conventional spinal at lumbar level to achieve a level of T3 to T4. So normally what we do if we are especially in some cases where cesarean section we give 2 cc and 1.8 cc and we see the drug essence still higher up around T6 to T4, so surgery can go comfortably. And in these cases, we give we give more amount of dose. So this dose can be reduced by if you are increasing the level of height of spinal anesthesia level. That is not giving at conventional levels and giving at thoracic levels. Local anesthetic drugs options and utility. Among the available drugs, isobaric drugs like 0.5% bupivacaine, levobupivacaine, 0.75 ropivacaine, and chlorprocaine, which is not used now, but initial studies, chlorprocaine 1% was used for segmental spinals. So why it was preferred? It's short acting and the volume required is quite high to produce desired level of anesthesia. So because of short acting, action, it was mostly preferred, but the amount of dose was high. So later on, its usage came down, which was replaced by our routine ropivacaine, levobupivacaine. Among these drugs, ropivacaine and bupivacaine, there are a lot of comparative studies were done. But for intrathecal use, ropivacaine is nearly half as potent as bupivacaine because of low lipid solubility. Ropivacaine has stronger differentiation between sensory and motor blocks. So initial studies, ropivacaine and bupivacaine were compared where most of the studies, they suggested bupivacaine only. And later on, bupivacaine was replaced by levobupivacaine. In the segmental spinal, now they suggest that using levobupivacaine is very much comfortable. Why? I will try to bring out some points. Levobupivacaine isobaric 0.5% low toxic profile than the racemic one. Low dose technique blocks sensory nerves in preference to motor ones. So this tends to preserve the muscle tone and power in the legs. So, and addition of small doses of fentanyl, clonidine, they increase the intensity of sensory block. And apart from that, the onset is gradual, hemodynamic stability, even with a high level of blockade, motor block time is shorter, leading to early ambulation, early bladder control. So onset for isobaric drugs at thoracic level, which is not much as compared to the lumbar levels. So the amount of CSF at thoracic levels is diminished compared to lumbar and cervical levels. The thoracic nerve roots are very thinner compared to segments above and below. Thus, there is less anesthetic dilution per segment unit of distance from the site of injection, and roots are easily blocked due to small size. So this is the main reason why low dose of thoracic segmental spinal in thoracic area is bringing us good results. because of the thin fibers which are present, there is less number of dose required, and we are getting ample effect. So onset time with isobaric solution in lumbar segments is longer than the hyperbaric solutions. When the injection is given in thoracic segments, the difference is not significant with the solutions. So what do you call initially when this procedure was discovered, so first chlorprocaine was used. Later on, anamine, that is our bupropion was used, and one study was conducted using bupropion, ropivacaine, and levobupropion. They concluded that there is what do you call no much of difference because between these things. Any solution is acting aptly only. Only one study came out with this point, but most of the studies they suggest that isobaric is more superior and that to levobupropion is very much useful. So, remarks and conclusions. Uh, Fact that anesthetic techniques is not usually done not means that it is wrong. Which is segment to segment we don't use regularly. We might think that it is something new, but it is a age-old technique which was not performed regularly. Might be some difficulties in giving the procedure where lumbar spinal was much more comfortable, and thoracic we have to put some angulations. For in thoracic area, high thoracic, 9-degree angulation was suggested, whereas in T6 to T10, 45 degrees angulation of the needle while giving the procedure was suggested. From T10 to L1 segment, again 8 degrees angle. While we are doing the procedure, our needle angulation should be 8 degrees at low thoracic, 45 degrees at mid thoracic, 9 degrees at upper thoracic. So a concept was developed that regional anesthetic should need no supplements, and that if it does, it should be considered a failed block. This reasoning needs rethinking. So when we are giving regional anesthesia, apart from blocking motor and sensory, we also need to see about patient general condition. Some people are apprehensive, so we need to add some additives like either in your regional dose or else by giving TIVA. So when we are supplementing anything else, it doesn't mean that the block is failed. Why this point was kept is when thoracic segmental spinals are performed, some patients have complained of discomfort. So they have used some midazolam or they have used propofol, and no studies because Dexmed is recently introduced. So no studies are came out with Dexmed use, but they have used fentanyl, propofol, midazolam, butyrum to sedate the patient because we are using low doses and some manipulations. Around 636 studies, patients were underwent this procedure, around which mostly around 78 patients they used what you call sorry, not 78, 178 patients they used these acting sedatives. But this doesn't mean the procedure is a failure because when compared to general anesthesia, if the patient is having comorbidities and we are giving general anesthesia, it will be much more complicated than giving minimal sedation. So patient safety takes precedence over the unnecessary risks to be taken for success of the procedure. So this is what I'm talking about. So patient safety, minimal dose of spinal with some sedation. If the surgery is being done, why unnecessarily go for complete anesthesia and extubation risk and all? And advantages: minimal hemodynamic fluctuations, minimal motor block, faster sensory recovery, early ambulation, and widening. And one more thing is for this technique, what they do is patient in supine or sitting position, select a level that is most commonly T10 level is preferred mostly. So give the block, take 1.25 or 1 ml of bupivacaine or any other ropican or levobupropion, add some additive if you think it is needed, or else go for 1.25 ml of spinal drug, give the drug, put this patient in supine position, and we have to examine the thoracic area levels, thoracic area region for pain and sensation. This is a regular procedure which we are doing for lumbar. Same thing here, but the thing is doses are reduced, and uh, onset time is also same as our lumbar spinal only. And main thing is monitoring is very much important, and vitals, heart rate, especially heart rate, because any capillary descent, immediately what you will see is heart rate comes down, and later on patient discomfort. Around in 636 segmental studies which were conducted, in 6 cases they have intubated the patient, out of which 3 cases patient had bradycardia, breathing in difficulty, and 3 cases patient did not get proper what you call patient complained of pain because of surgical intervention. Even though they sedated, it was patient was having unbearable pain, so they intubated. So out of 636, 3 6 you can call it as procedure failure, and 178 needed sedation. So I think a good number of cases can be done in segmental spinal. So personally, I have not done a single case of segmental spinal, but if anyone have done segmental spinal, please share your experience with us. These are my references, and thank you all.
Thank you very much. It was a nice topic, but only thing is that even I have not.
Hello. 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 Sir, am I audible, sir? Hello.
Yes, it is audible. Thank you very much. It is a nice topic which is trending now. Can you hear me?
Yes, ma'am. Yes, ma'am.
Hello.
Thank you.
Yeah,
Yes.
which is in trend now. So few of my colleagues have done, but even I am unaware of that. If you want, I can tell her to talk.
Yes, ma'am. Please, ma'am, because
Yeah. Wait. I'll try to connect her.
okay, ma'am.
Nice talk, Dr. Omkar.
Thank you, madam. Thank you.
Please give me conclusion once repeat.
Conclusion, we can use segmental spinal for any abdominal surgery, madam, comfortably, and especially if patients are having comorbidities, then we have to put it in, we have to first think of segmental spinal, and then if you are failing, then you can go for your regular general anesthesia. And we have to counsel the patient properly.
సెగ్మెంటల్ రాదా ఛాన్సెస్ ఎంత పర్సంటేజ్ ఆఫ్ నాట్ గెటింగ్ సెగ్మెంటల్ కరెక్ట్ గా వస్తుందా?
స్టడీస్ ప్రకారం అయితే సెగ్మెంటల్ బాగానే వస్తుందని చెప్తున్నారు సార్. చెప్పారు కదా 636 పేషెంట్స్ చేశారు సార్.
అంటే ఎట్లా చేయాలి సెగ్మెంటల్ అనేది?
ఏం లేదు సార్, థొరాసిక్ లెవెల్స్ సెలెక్ట్ చేస్తాం సార్. ఇప్పుడు బ్రెస్ట్ సర్జరీ అనుకోండి, ఇఫ్ యు ఆర్ గోయింగ్ ఫర్ బ్రెస్ట్ సర్జరీ వి గివ్ థొరాసిక్ ఎట్ అరౌండ్ T6 అండ్ అబ్డామినల్ సర్జరీస్ అరౌండ్ T10.
సార్ ఇప్పుడు ఇంతకు ముందు మనం ఎపిడ్యూరల్ చేసాం కదా సార్, like wherever we want to make that 2-3 segments below and 2-3 segments above, అలాగనే ఇప్పుడు స్పైనల్ కూడా చేసేస్తే the side effects of spinal anesthesia, so high level of anesthesia can be prevented, sir. But only thing is that experienced anesthetist only can give high segmental spinal. You cannot keep on poking.
Okay.
Sir, Raman Prasad sir, any comments, sir? Any suggestions?
Omkar, you are following segmental, huh?
లేదు మేడం, యాక్చువల్లీ దిస్ వాస్ సజెస్టెడ్ బై వన్ ఆఫ్ మై కొలీగ్ మేడం who was in Kakinada RMC. They have done 2 cases it seems. So I took some material data from them and worked, and Srikanth sir also gave some data. Basing on this, we prepared a class. They are doing. I did not do a single case, madam. So I think I will start doing this segmental spinal. I think you can give any DNB this what you call thesis topic, madam.
No, but these PG students should not do that high level spinal, because that otherwise they can just monitor, check the levels.
Yes, madam, because they do everything under some seniors presence now.
అంటే spinal prick చేయలేరు అది వేరే అన్ని చేస్తారు.
Yes, madam.
Even seniors can do that study, because one of my colleague, batchmate who studied DNB with me, she has lot of papers on that.
Okay, madam.
I
So-
will share it in the group.
Are they practicing now,
Yes,
madam?
yes. So she told she's practicing that even spinal injuries. So that thing is covered. Even in prone position also.
Even I went through one study, madam, where segmental spinal was used for lap cholecystectomy, but nothing was what you call mentioned in the intraoperative complications and all. It was like we did a study and it was giving good results and all. Because lap surgeries, we need to know what pressure they are using. One study which I saw, it was like COPD case.
Positions.
Hello. Hello. సార్ అదే వినపట్లేదు, మేడం ఏమైనా చెప్తున్నారేమోనని. సార్, ఎనీ అదర్ సీనియర్స్ కెన్ షేర్ దేర్ ఎక్స్పీరియన్స్ సార్ రిగార్డింగ్ దిస్ segmental spinal? Any questions or any queries, sir, please?
I think
Sir,
now after your class will start.
Sir, Omkar sir, good morning. PG students, I want to ask one anatomical question. Can I ask?
Sir, you can ask us. We also don't know anything about segmental spinal, sir.
What is the artery of Adam Kivix? DNB students.
ఓంకార్ సార్
Sir,
Sir,
sir.
ఇప్పుడు వాళ్ళు ఎక్స్పీరియన్స్ అడుగుతున్నారు. ఐ హావ్ ఎ లాట్ ఆఫ్ ఎక్స్పీరియన్స్ నాట్ డూయింగ్ ఎ స్పైనల్. వెన్ యూ గివ్ స్పైనల్ ఇట్ హస్ బికమ్ సెగ్మెంటల్, వి ఫెయిల్డ్ ఇట్. దట్ వాస్ అవర్ ఎక్స్పీరియన్స్ మోర్.
Sir, actually, the concept of segmental spinal, it started with failed spinal only, sir. They have noticed that some area there was fibers were blocked and some areas fibers were not blocked. And later on, they started working on it. And finally, Janesco, he came up with this concept. He got this idea of segmental spina from failed spinals only, sir. Hello, sir. Round process, sir.
అర్థమైంది. అలా అనుకుంటే ఆర్ట్స్ నెట్ ట్రయల్ కూడా వెరీ వరల్డ్ ఫేమస్ ట్రయల్. ఇట్ వాజ్ నెగిటివ్ ట్రయల్. సో అది ప్రాబ్లం లేదు. బట్ స్టిల్ దిస్ ఇస్ రియల్లీ గుడ్ అనమాట. నాకు అంత కరెక్ట్ గా వస్తుంది నాకు నమ్మకం లేక అదంతా ఫెయిల్ లోనే చదివాం కదా, బాధపడేవాళ్ళం. సెగ్మెంట్లు వచ్చిన వల్ల బాధపడేవాళ్ళం. సో
సార్ రౌండ్ ప్రొసెస్ సార్, అదే మీరు అడిగిన ఆర్టరీ runs right side of vertebral column and most commonly puncturing that will lead to spinal syndrome, sir.
Sir, spinal cord is separated by 2 anterior spinal and 1 posterior spinal artery, sir.
Sir.
On the lateral side of the spinal cord, there will be anastomosis between these 2 arteries. At the thoracolumbar level, there is this anastomosis is enlarged.
Yes.
And it is called artery of Anabi.
Okay.
Sir, do you practice mid-spinal or paraspinal approach in thoracic for epidural?
Regular thoracic epidural we do, sir. Spine, mid-spinal and segmental, when it is very difficult, we are not able to do. We try segmental. What they call paraspinal, but spinal I have never given, sir.
Segmental spinal can also be given through epidural, sir.
Segmental spinal, sir.
Segmental block.
Okay,
Yeah,
sir.
that it is catheter putting into the spinal cord, subarachnoid space. No, sir?
I have a doubt. If you give at that level and a minimal dose and block those segments, can it be called segmental epidural?
Sir, epidural space itself is having negative pressure, and when we are depositing dose, it gets sprinkled up. And
Okay.
for that, we have to give a lot of volume, sir. With low volume, I don't think we can get segmental spinal properly by doing epidural, sir. If you're depositing more amount of dose, I think it's possible. But with minimal dose, getting segmental spinal by epidural, I think it's difficult, sir.
One of my seniors used it. He has practiced several hundred. If for simple mastectomy, he used to give epidural at the level of T5 to T6.
Okay. Any idea about volume sir used to use, sir?
12 to 14 ml.
12 to 14, sir. Okay.
But not radical. Only simple mastectomy. If there is axillary clearance, you have to go for general.
Yes.
ఎందుకు చాలా మంది అలాంటి వాటికి ఈవెన్ ప్లాస్టిక్ వాళ్ళు కూడాను లోకల్ అనస్థీషియా ప్లస్ అది కలిపి ఇచ్చేవాళ్ళు ప్లాస్టిక్ సర్జన్స్. అదేనా మీరు చెప్పేది? అదేనా చెప్పేది మీరు?
సార్
లోకల్ ఏనా చెప్పేది?
లోకల్ చెప్పేది అది వేరు సార్. ఇది సెగ్మెంటల్ ఎపిడ్యూరల్ లో థొరాసిక్ ఎపిడ్యూరల్ లో సింపుల్ మాస్టెక్టమీ చేస్తున్నారు సార్. చాలా సెంటర్స్ ప్రాక్టీస్ చేస్తారు.
అంత ఎంఎల్ కరెక్టేనా? అంత ఎంఎల్
Actually, single dose, I used to give 15 to 20 ml for mastectomy, for 2 to 3 hours.
No, thoracic epidural is off the lumbar epidural dose.
హలో సార్, థొరాసిక్ ఎపిడ్యూరల్ లో మాస్టెక్టమీ నేను 4-5 కేసులు చేశాను సార్. ఈచ్ 12 ml ఇచ్చేవాడిని.
అంతే రైట్.
8 to 12 ml ఇచ్చేవాడిని. నేను 4-5 కేసులు చేశాను థొరాసిక్ ఎపిడ్యూరల్ మాస్టెక్టమీ. హలో,
The duration also depends upon the volume.
పొజిషన్
So,
వల్ల
for
segment
longer,
అవుతా?
సార్
జయరాం కాలు పైకి లేపి హెడ్ పెడతావా?
అర్థం కాలేదు సార్. పొజిషన్
హెడ్ అప్ లెగ్స్ అప్ పెడతావా?
ఏం పెట్టండి సార్, మామూలు ఫ్లాట్ పొజిషన్ పెట్టేవాడిని. అది క్యాథెటర్ వేసుకుంటాం సార్, మనం క్యాథెటర్ వేసుకొని 8 నేను ఎక్స్టెండ్ చేసేవాడిని కూడా కదా. సర్జరీ ఎక్స్టెండ్ అయితే నేను ఎక్స్టెండ్ చేసేవాడిని కూడా, మళ్ళీ డోస్ 3 ml 4 ml ఇచ్చేవాడిని కూడా నేను.
సార్ అది న్యాచురల్ కర్వేచర్ ఉంటుంది కదా సార్, అంటే ఇట్ డజంట్ గో డౌన్ సో ఫాస్ట్. అండ్ ఆల్సో ద వాల్యూమ్ గివెన్ విల్ బి లో ఇన్ థొరాసిక్ ఎపిడ్యూరల్.
చాలా 8 to 10 ml సరిపోతుంది. అండ్ 3 ml ఇచ్చేవాళ్ళు.
ఆర్ఎంసీ లో పీజీ లో లెఫ్ట్ అండ్ రైట్ వేసేవాళ్ళం సార్ మేము థొరాసిక్ ఎపిడ్యూరల్.
నేను కూడా ఎక్కువ వేసాను పీజీలో కూడా, ఐ మీన్ కేజీస్ కూడా వేసాను. 2-3 సార్లు ఫెయిల్ అయ్యేవి కానీ, అంటే ఎపిడ్యూరల్ స్పేస్ లోకి వెళ్ళలేకపోయేవాళ్ళం కానీ, మామూలుగా అయితే వెళ్ళేవాళ్ళం. నేను బయట ప్రాక్టీస్ చేసిన కూడా చేసేవాడిని.
సీనియర్ ఒక అమ్మాయి ఇచ్చినప్పుడు 2-3 సార్లు సీజర్లు కూడా వచ్చాయి.
సార్ అదే సార్, ఇప్పుడు మనం వేస్తున్న రెగ్యులర్ థొరాసిక్ కి మనం వాల్యూమ్ ఎక్కువ వాడుతున్నాం కదా సార్, 8 నుంచి 15 ml వరకు వాడతారు. అంటే ఇప్పుడు ఏంటంటే ఈ లో వాల్యూమ్ తో ఎంత వరకు చేయొచ్చు అనేది సార్, అంతే. సెగ్మెంటల్ స్పైనల్ కి దానికి
సెగ్మెంటల్ స్పైనల్ కూడా లో వాల్యూమే కదా, 2 to 3 ml ఇస్తాం మాక్సిమం.
3 కూడా లేదు సార్, 1.25 to
3 కూడా లేదు.
1.5
అదే సేమ్ సిజేరియన్ సెక్షన్ లో ఇచ్చినట్టుగానే
ఇచ్చినట్టు ఇవ్వడం అంతే. సో అంటే సార్ థొరాసిక్ దీంట్లో అడిగారు కదా, నేను అన్నానంటే వాల్యూమ్ ఏమైనా 3-4 ml చేశారేమోనని. అంత తక్కువ అవ్వదు కదా సార్.
వాల్యూమ్ ఇంపార్టెంట్, కాన్సన్ట్రేషన్ తగ్గించుకున్న వాల్యూమ్ ఇస్ ఇంపార్టెంట్.
వాల్యూమ్ ఇస్తే మనకి తీసుకోవచ్చు.
నాకు ఒకసారి 2 సార్లు కంటిన్యూ లాస్ట్ చేసిన 2 సార్లు పేషెంట్ వాయిస్ పోయింది, బయట లేదు. సో అప్పటి నుంచి నేను థొరాసిక్ ఎపిడ్యూరల్ ఇవ్వడం మానేశాను. హలో
సార్,
నేను 2 సార్లు థొరాసిక్ ఎపిడ్యూరల్ ఇచ్చినప్పుడు పేషెంట్ వాయిస్ పోయింది, వైటల్ కెపాసిటీ లేదు, ఈజ్ అనేబుల్ టు స్పీక్. అప్పటి నుంచి నేను థొరాసిక్ ఎపిడ్యూరల్ వేయలేదు ఇంక తర్వాత. మళ్ళీ నేను
వాయిస్ కూడా పైకి వచ్చిందా?
సర్వైకల్ ఎపిడ్యూరల్ వేసాడు సార్.
వాల్యూమ్ కొంచెం పైకి వెళ్ళేసరికి వాల్యూమ్ పోయింది, అదే వాయిస్ రావట్లే. బట్ పేషెంట్ వాస్ కంఫర్టబుల్, సాచురేషన్ మెయింటైన్ అయింది. సర్జరీ చేసాం కానీ 40 minutes నేను చాలా టెన్షన్ పడ్డాను, అందుకని తర్వాత వేయలేదు నేను మళ్ళీ.
చూడాలి సార్, సెగ్మెంటల్ స్పైనల్ చేసి ఎలా ఉంటుందో చూడాలి ఇంకా. బట్ అదే సార్, ఈ అక్కడ చేస్తున్నారు కదా, మనం మెయిన్ గా టేకప్.
కానీ కాకినాడ చేసేవారు సార్, నేను వే బ్యాక్ 2014 కాకినాడలో నేను ఎస్ఆర్షిప్ చేసినప్పుడు అక్కడ కొలిసిస్టెక్టమీలు సెగ్మెంటల్ స్పైనల్ చేసేవారు. నాకు 2-3 కేసెస్ గుర్తుంది. చేసేవారు కాకినాడలో అయితే ప్రాక్టీస్ చేశాను నేను. ఏం ఇప్పుడు చూడలేదు కానీ కాకినాడలో చేశారు.
సార్ ఏం లేదు సార్, నా డౌట్ ఏంటంటే ఇప్పుడు ల్యాబ్ కొలిసిస్టెక్టమీ మనం సెగ్మెంటల్ లో చేసేటప్పుడు ఈ ఎంతో కొంచెం డిస్టెన్స్ చేసేటప్పుడు ఈ డయాఫ్రమ్ ఇరిటేషన్ అన్ని వస్తాయి కదా సార్. మరి డయాఫ్రమ్ కి పై ఎక్కడి నుంచో కదా నర్వస్ సప్లై వచ్చేది. సార్
మామూలు ల్యాబ్ కేసు ఫైనల్ చేయట్లేదు నేను చాలా రోజులు అసలు, ఆల్మోస్ట్ ఇయర్స్ అయిపోయింది, 2-3 years అయిపోయింది.
స్టడీస్ గురించి చేశారు సార్, ఆ స్టడీస్ లో ఎక్కడ కూడా ఇంట్రాప్ ఏం జరిగిందో ఇవ్వలేదు. అంతా కూడా ఏసేమో బానే ఉంది అంటున్నారు అంతే. మన కాకినాడలో జరిగిన కేసు గురించి కూడా కనుక్కున్నాను, వాళ్ళు డైరెక్ట్ చేస్తారు అంటున్నారు సర్జరీ.
ఇవన్నీ ఇండివిజువల్ ప్రాక్టీస్ లో చేయడం కష్టం.
ఇండివిజువల్ కష్టం, అందుకే డిఎన్బి పీజీలో వచ్చినట్టే ఇది ఏమైనా చేయగలం.
ఏదో ఇన్స్టిట్యూట్స్ లో చేయగలం తెప్పించండి, బ్యాకప్ ఉన్న ఇన్స్టిట్యూట్స్ లో 2-3 అనెస్థిస్టులు ఉండే చోట హెల్పింగ్ హ్యాండ్ యూ కెన్ గో అహెడ్ విత్ దిస్ ట్రిక్స్. కానీ సింగిల్ సోలో ప్రాక్టీస్ చేసేవాడు ఇట్స్
Bonkar, after segmental spinal, for post-op analgesia, you can insufflate bupivacaine 20 ml with 25 mg of dexmedetomidine, and also gallbladder cloza. It gives very good post-op analgesia. The surgeon will diffusely infiltrate through the spot. These drug will be.
Yes, sir. We have also done this, sir. Giving spinal and for appendix, we have done in regional only, where we are giving just spraying the anesthetic drug towards diaphragm, sir.
Yeah.
But nothing was mentioned about this block and or anything in the studies, sir. They directly mentioned that I will put the studies in the group also. They have done lab coli and all. No mention about this thing. Even when this pressure is done in Kakinada also, they never spoke about this giving. After putting port, surgeon will flush the lower part of abdomen with what you call our cocktails. Nothing like that. They're directly going ahead with surgery.
No, after the removal of the gallbladder, you have to give this for post-op analysis.
So, Mari stretch ki reflex also basically regional.
There are several studies and papers published.
Sir.
I have also seen in KGH, patient will not have any pain if you insufflate this mixture into the fossa of the gallbladder and throughout the peritoneum through ports.
Sir. I myself did around 10 cases regional, sir, lab appendix we have done, where after putting the port, surgeon, we used to prepare cocktail with 5 ml lignocaine, 5 ml anavin, and surgeon used to push that dose through the port towards upper area, that is towards liver and all, so that drug will diaphragmatic irritation can be reduced. Most commonly, immediately if you are doing any lab surgery in regional, first complaint from the patient is right shoulder and right back pain. For every surgery, to stop that pain, we did this, and around in 10 cases, 8 cases we are successful, and patient never complained of any pain, and he also brought the spinal level to around T4, and then we have done this. But in segmental spinal, means how they are knocking off, I don't know. So I don't have the reason. They are never mentioned about giving any block intraoperatively. So the block which you have mentioned, sir, we give it before immediately when port is kept. We will give minimal CO2 pressure, and we will give the drug, so that it will help if you are putting too much of pressure in the abdomen because of the distension. Diaphragmatic irritation can be reduced. But these studies, nothing is mentioned. I don't know why. Hello?
Sir.
Sir. Okay,
this can be given for one of the DNB students for study.
Okay, sir. Okay, sir. Okay.
ఏంటి ఎవరు మాట్లాడలేదు? అయిపోయిందా ఓంకార్?
ఇంకేమైనా పాయింట్స్ చెప్తారని వెయిట్ చేస్తున్నాను సార్.
Thank you, Omkar. There are 2 points. One is definitely your slides are very color అంటే కరెక్ట్ గా కనపడుతున్నాయి స్లైడ్ లో చూస్తుంటే. మామూలుగా ఎప్పుడు స్లైడ్ లో చూసినా కలర్స్ కనపడదు కదా. రెండోది సైజ్ ఆఫ్ ద లెటర్స్ అండ్ సైజ్ ఇస్ సఫిషియెంట్ క్లియర్ ఏబిలిటీ విజిబిలిటీ బాగుంది. థ్యాంక్ యూ.
థ్యాంక్ యూ సార్. ఆ గొప్పతనం అంతా మా ఆవిడకి వెళ్తుంది సార్.
అలాగే ఆమెకే చెప్పు కంగ్రాచులేషన్ సార్, థ్యాంక్స్ చెప్పు. రైట్.
థ్యాంక్ యూ సార్. థ్యాంక్ యూ.
Thank you, Omkar. Thank you to all.
Thank you, madam. Thank you all for your patient listening. Thank you.